Welcome, everybody. This is our monthly webinar, and this is the month of March. So we're here for our March customer webinar, and I am here with our favorite Winona doctor, Dr. Mike Green. And I'm going to turn things over to him so we can get started and take it away.
So, hi, my name's Dr. Michael Green, Mike Green. Dr. Kat is hopefully on her way. She was supposed to join us, but she got called to the emergency room to see a patient. So we are real doctors and we do real work. So hopefully it'll be an easy one and she'll be back to join us. But for now, I'll take over the questions. So the point of this is a question and answer. So start typing in your questions now, because otherwise I'm just going to be yakking away and that won't be any fun for anybody. So type your questions into the chat and we'll get to them. So let me give you a little introduction for those who don't know me. My name's Mike Green. I'm an OBGYN. I actually did a family practice residency years ago and decided I didn't really like taking care of sick people. So I did OBGYN. I love delivering babies, and women's health is a passion for me. And so I've been doing this for a long time. I finished residency in 99. What's that, 23, 24 years. Taking care of women through various stages of their life, catching their babies, doing their hysterectomy, taking care of their menopause problems, all kinds of things. So I am the Chief Medical Officer of Winona, and we really want to educate our patients. So I've always felt that my job as a physician is mostly as an educator, to explain things in a way that my patients can understand. Explain the various options for treatment so that they can decide what's right for their unique individual situation. So that's really the idea, is to answer your questions, to educate you, to make sure you understand what's going on. It's your body, and it's really important that you understand why we're suggesting and prescribing the medications, and how to problem solve things that come up. I want to take just a couple minutes as your questions are coming in to talk about. I usually talk a little bit about something basically to kill some time while you put questions in. But there's an important topic. It's been coming up a lot, so I assume somebody's on social media talking about this and confusing the heck out of people. And that is the difference between continuous HRT and intermittent HRT. And so sort of the traditional way to do hormone replacement therapy for women that need progesterone is to give estrogen and progesterone daily. Every day, no matter what happens with your menstrual cycle, you just take this medicine like we do most medications. You take them every day. And that works really well. And it's sort of the way all the studies have been done. It's where the research is based. There are some studies on other methods, but this is sort of the gold standard. And it's the approach that we prefer to use as well. Some people use what we call intermittent hormone replacement therapy, where they give estrogen every day, but they only give progesterone sometimes. And there's different ways to do this. Some people will give the progesterone every other day. Some people will only give it 7 days or 10 days or 14 days out of the month. Some people will give it 14 days every 3 months. So these are all different strategies that people employ, hoping that they can improve on the gold standard, on the everyday HRT. And there's several reasons for this. I think the first one is a confusion with birth control pills, because it's the way birth control pills are packaged. You take 21 days of real pills and 7 days of fake pills. And so there's a cycle that happens with birth control pills. There are different kinds of pills, but in general, that's the way birth control pills work. But they're really designed for a totally different thing. They're designed to keep you from getting pregnant. And they really have a giant dose of hormone that takes control of your ovaries. Shut your ovaries down, and all your hormones come from the birth control pills. And that's why they're done this way. Hormone replacement therapy is completely different. It's really a replacement. So it's a small dose that comes alongside what your ovaries are already producing, and gives you that extra little bit that you need. And the thing is, you need that extra little bit every day. And so it makes more sense to dose it every day. There was also, there's some studies that came out that were kind of surprising for everybody. And what it showed was that when estrogen alone was given for hormone replacement therapy, there was no increased risk of breast cancer. When estrogen and progesterone were used together, there was a slight increased risk of breast cancer. It was pretty teeny, but it was there. And so people thought, well, gee, maybe it's progesterone that's a problem, so maybe we should decrease the amount of progesterone that we're giving. And that's another reason why some of these intermittent methods were done. The problem is there's been no studies that have shown that it worked. So it doesn't seem to matter how you give the progesterone, that increased risk is there anyway. So in my opinion, and there's a third reason, it's kind of an ugly reason, and that is that for some people, for some doctors and some people in general, they like to make things more complex. If things are more complex, people think, oh, this must be better because it's so complicated and difficult to use. And so something that's difficult to use must work better. And honestly, most things are the opposite. Keep it simple, right? KISS, keep it simple, sweetheart, right? And so, generally my experience in life and in medicine is the simple approach is often the best approach. And just because something's more complicated doesn't make it better. And in fact, there's downsides to be complicated in that, oh, there she is. And then one of the downsides, hey, this is Dr. Ryan, Kat, back from the ER. One of the important things of keeping it simple is it's easier to do it right. And so if you make things complex, people are more likely to make a mistake or mess up or forget. And then it kind of messes up the whole thing and can cause a lot of side effects. So in general, for most people, I found that continuous hormone replacement therapy, taking estrogen and progesterone every day, each and every day, no matter what's going on with your cycle, tends to work the best. And that's what I generally recommend. So I'll let Dr. Kat introduce herself and then we'll hit some questions.
Hi, I'm Dr. Kathleen Brown. I'm our Winona doc in Pennsylvania and also recently just started taking care of patients in Florida as well. And I am on call tonight, so I might have to run and deliver a baby here or there, but that's why I wasn't here when you guys first started. But I'm committed to women's health and here to answer your questions and address any of your concerns.
Yay! Glad you made it.
I know, me too.
Okay, so let's get started. We have lots of questions already. So I don't know who wants to take this first one. The question is, how long can I stay on hormones? I'm 59. How long should you stay on it?
Well, I would say you'd stay on the hormones for as long as you need them to treat your symptoms if they're affecting your quality of life. So it's important for us that we start hormone therapy before the age of 60, but you've already been on them by 59. If you try to go off of it and you start to notice your symptoms coming back, then maybe we can, go back on it. Most patients are on it on HRT for maybe a few years, sometimes up to 5 years. But really, it's a matter of risk and benefit for you and really your quality of life and how your symptoms are. There's no expiration date or time limit. It's unique to each patient.
Great. Okay, good. We have a question about the dosing on estrogen and progesterone. It says, I've started the WBIEST 50/50 progesterone cream, trying to figure out the dose of estrogen and progesterone.
Let me just jump in, grab your bottle because you didn't give us enough information to tell you that. So there's a number that'll be a fraction, like 3,150 or 5,200. So if you can type that in for us, we'll get back to you and then we can tell you what dose you're on.
Next, excuse me, the next question is about water retention. Does water retention fluctuate? Some weeks I look and feel fatter and some weeks I look thinner.
Well, it really can fluctuate, from day to day, from week to week, depending on what you're eating, what you're drinking. Salt intake can affect that as well. When you first start your hormone replacement therapy, sometimes you might notice a little bit more bloating than usual, and sometimes that's just your body acclimating to the medication. So something to keep an eye on. If you're noticing a pattern and it seems to come and go like this, you might want to start kind of journaling as to what foods you're eating, what your water intake is, and just kind of keep track of it for yourself so you can kind of see if there's any rhyme or reason to it. And then you can make adjustments to try to prevent it.
Great.
So I can tell you that even a guy has the same problems. And one of my little things I do, which is probably dishonest, but before I step on the scale, I take my ring on and off to see how tight it is. If it's really tight, I don't bother. So, water fluctuations happen with everybody. But yeah, sometimes at the beginning of treatment, they can be more pronounced.
It's a good trick, Dr. Green. Okay, we have a question about results. I started estradiol, progesterone, and DHEA a few days ago. I'm 8 years post-menopause. When can I expect to see results? And is it common for my fatigue to decrease with HRT?
Want to grab that, or you want me to?
Go ahead and grab that, Dr. Green.
The results can be really variable, and it sort of depends on the symptoms. Some symptoms tend to get benefit right away. Hot flashes, sleep disruptions. We tend to see at least some benefit early on, but even that, it can take a few weeks before you even really notice any of that. And for some people, it takes longer. Other things like weight changes, muscle gains, those in hair and nail changes, and even some skin changes, those can take a lot longer, in the order of months, before you really notice a lot of changes. And honestly, there's a huge spectrum here, so everybody's a little different. HRT definitely can help fatigue, especially a lot of women have sleep disturbances from the menopause transition. Hormone replacement therapy often does one of the big things it does for a lot of women is to help them sleep much more soundly and thoroughly and not wake up all night long, and that in and of itself can help fatigue. But also the DHEA in particular, but the estrogen-progesterone as well, can also help fatigue for other reasons during the day. So yeah, that is something that I think you can expect to get relief from. Sometimes we have some patients that it's crazy effective, and they're like, oh my gosh, 3 weeks in and I feel like a totally different person. Other people, it's a really slow, gradual process. And I've had lots of patients, several, over the years, where they don't think it's doing anything, and so they stop it, and then in a month or two they come back and like, oh, I didn't realize how much it was helping me. Can I restart it, please? So sometimes it's like, that boiling a frog thing. It's a slow, gradual process, and you almost don't notice the benefits. Journaling can be really helpful to see how things are changing.
Great. We have a question about alcohol consumption. How much alcohol is okay to consume weekly? I was told that alcohol increases a type of estrogen called estrone, which is not good and can cause breast cancer.
My general answer for anybody's question whenever they ask me how much alcohol is okay is moderation is key. In my opinion, maybe a glass of wine with a meal here or there might be okay, but you might notice when you're drinking alcohol that it might exacerbate your hot flashes and your night sweats. And so if that's happening, then that tells you that your body may not tolerate that glass of wine here or there. But definitely trying to keep it to no more than 1 or 2 drinks at a time. Moderation is key. I don't know if you want to speak to the estrone a little bit more. Dr. Green is a little bit more savvy talking about the hormone conversions and stuff.
Yeah, I don't know that that's a big issue, quite honestly. There is some surprising data. There's a lot of mixed data about alcohol. But for women, consistently 1 or 2 drinks a day can be enough to really affect the liver. And that can affect all kinds of metabolic problems, which is kind of surprising because you also read, you read these articles, oh, a glass of wine a day is good for your heart, and, all these different things. The bottom line truth is if you ask a doctor how much is too much, they kind of think about how much they drink and figure, well, as long as you don't drink more than that, which is a really lousy way of doing medicine, but we are. But in general, yeah, moderation is clearly important. I don't know that I don't know of any quantitative studies that have looked at estrone and the amount of alcohol it takes to have that problem. But I think
I don't think I've ever seen anything written about that either.
Yeah, I'm not aware of any studies like that. But in general, like most things, moderation is key.
Okay, good. Our next question is, this is about DHEA. I take DHEA in the morning and progesterone cream at night. Should I take them together?
Well, really, it's about what works best for you. So for my patients, I tell them, however it works into your schedule, most patients tend to get maybe a little bit of drowsiness with the progesterone, so taking that at nighttime might be helpful. But every patient is different. If it's hard for you to remember to take it in the evening and it's better for you to get your medications done in the morning so they're all done for the day, that works too. You can kind of use a little bit of trial and error to see what works best for your daily schedule, because it's more important to remember to take it each day, not the specific time that you take it.
Okay, we have a question about, this is about results. How long does it take to feel a change from the therapy? I started 6 weeks ago and mostly feel worse.
That's not a nice thing to hear, that you feel worse. If you were my patient and you wrote me that in the dashboard on our Winona platform, I would want to know a little bit more detail about why do you feel worse? Like, what are the symptoms that are getting worse? For the most part, when we have a good dose and we've made that good match for you as far as what we need to treat you with, you should start noticing some improvement within a few weeks. Some of the other benefits of the hormone therapy, like weight loss and things like that, might happen a little bit later. But initially, you should start to notice some improvement in your hot flashes and night sweats within the first few weeks. So if you're starting to notice that things are worse instead of better, you need to write to your doctor and talk to them about that. Let them know what you're feeling, because it might be that our best guess for the algorithm to come up with your first dose might not be what works best for you. We might need to tweak it. So write to your doctor.
Okay, our next question says, I have significant health anxiety and I'm concerned about the safety of bioidentical hormone replacement therapy products. My dietitian suggested I try bioidentical products. My PCP had never heard of bioidentical hormones. Should I be concerned about cancer and blood clots with BHRT or the DHEA capsules? I don't have a family history of breast, uterine, or ovarian cancers.
So I'll get this one. If you look at the big picture and you look at women that sort of survive our screening, so they're good candidates for hormone replacement therapy, and you compare them to women that never take hormone replacement therapy at all, women that take hormone replacement therapy are more likely to live longer, healthier lives. So the big picture is, for most people on average, your risk of dying is less on hormones than off hormones. It doesn't mean you can't have side effects, and it doesn't mean things can't happen, but things happen to people all the time, whether they're on hormones or not. So that's the way I like to look at it. Now, you can parse it out, and like I said before, there is data that women that are on estrogen and progesterone hormone replacement therapy have a slight increased risk of breast cancer than women that aren't. But on the other hand, they have a lower risk of colon cancer, they have a lower risk of endometrial cancer, they have a lower risk of heart disease and heart attack and other cardiovascular problems. And so when you balance it all out, you're much more likely to live a longer, healthier life with it than without it. And so to me, that's kind of the answer there. You can look at each individual thing. Well, yeah, you have a little bit higher risk of that, but you have a lower risk of this, and then you have trade-offs. But the big picture is, with the hormone replacement therapy, you're more likely to get what you want, which is, that's what we all want. We want to live long, we want to live healthy lives. A word about your PCP. So bioidentical hormones is it's a bit of a catchphrase, and basically it's an important thing. But basically what it means is that the hormones that you're getting are the exact same hormones that your body makes. And that's different than some of the hormones out there. There are synthetic hormones that are made in a lab that aren't exactly the same as what your body makes naturally. There are also hormones that are, believe it or not, derived from horse urine, and they have a whole bunch of horse hormones that aren't what humans naturally have. They work because they're still estrogens, but they're not the exact same estrogens. So bioidentical hormones really just means that we're using the exact hormones, chemically identical to what your body makes. And it's a bit of a catchphrase, but I think it's an important distinction because there's evidence, and we believe, and logically it makes sense that you're going to do better taking what your body normally makes than taking something synthetic or something from a different mammal. The other thing is that depending on how old your PCP is, there was sort of a loss of education in medical school and residency for a bit of time because everyone got afraid of hormone replacement therapy based on a study that was misinterpreted basically by the media and kind of caused this big panic. And so people were in residency, where they're training, and it was like, look, you got a lot to learn. No one's ever going to use this stuff, so don't bother. And so a lot of doctors never really got trained well on hormone replacement therapy, which is really unfortunate. And so, I'm sure your PCP is a great doctor, but none of us know everything about everything, that's for sure. And so we all have, some holes in our education. We all do really good at one things and not as well at others. And so, it's something that, number one, it just may be a name thing. And number two, it just might not be a type of medicine that your PCP practices, which is fine. And, we're here to help with that. And really, in medicine, we lean on other doctors all the time. So we get what's called consults, or we send people to specialists or subspecialists or super subspecialists. We used to tease, about, the left eye retina specialist, in ophthalmology. And that's a normal part of medicine because nobody can be an expert at everything. And so it's sort of normal for us to say, hey, you know what? This isn't my area of expertise. Let me send you to Dr. So-and-so, and they'll do a much better job than I can of this. I do that all the time with my patients. And that's a good doctor that does that, really.
Thank you, Dr. Green. That was a very good and thorough answer.
Sorry for the rabbit trail. I just realized that wasn't really what you asked.
Thank you. Okay, I want to circle back to our first question because since she was the first person to ask and we needed more info, her question, let me just scroll back here, was about figuring out the dose of estrogen and progesterone. So Jules says she has 3/150.
So that's the 3 milligrams of estrogen and 150 milligrams of progesterone that are delivered in that cream when you give 2 pumps.
Actually, it's 3 milligrams per ml. 2 pumps is half an
per
ml.
ml, yes.
Yeah, so you're actually getting half an ml if you do the math. And then if you really want to dive down deeper, the 3 milligrams of estrogen is half estradiol and half estriol. So you can divide it further if you want to be a math major. And then the progesterone is micronized progesterone, but it's per ml, and 2 pumps is half an ml.
All right, we have a question about fatigue. Is fatigue one of the side effects of menopause, and for how long? My fatigue is random and I have to rest before regaining my energy.
It certainly is something that you can experience during perimenopause or menopause. I mean, actually, if you look up the symptoms of menopause, it's a very lengthy list. It's not just hot flashes and night sweats, but fatigue is something that is pretty prevalent in my patient population. Some of it could be because your sleep quality has been affected, and it can be related to the insomnia in the evening. And sometimes you might not be getting great quality of sleep, even though you don't know it. You wake up in the morning and you might not feel refreshed, but you'll remember waking up several times in the night. But it's definitely something that can affect patients at this time. And so hormone therapy can help with that.
Great. Okay, the next question is about surgical menopause. Are there special instructions on taking HRT when you're in surgical menopause?
Well, it all depends on when you had your surgery. So when we talk about surgical menopause, that usually means the surgical removal of the ovaries, which are the source of your body's own endogenous or its own estrogens that it creates. So for me as a gynecologist, if I have a patient that is 30 when she has her ovaries removed, I'm starting her on hormone replacement therapy right away because I want to replace those things that I have removed surgically. So typically it's about maintaining a consistent level until you would have gone through the natural age of menopause for those patients that have surgical menopause early. I don't know if you want to add to that, Dr. Green.
My experience is that women that have undergone surgical menopause tend to need a higher dose of estrogen than women that are going through a more natural menopause process. And I think the reason is, as you go through the menopause transition, it's not like your ovaries are working one day and the next day they stop working. It's a slow, gradual process, and it's little spits and sputters even. And so when we replace the hormones, we're giving you back the hormones that your ovaries aren't making anymore, but they're still making some, and so you don't need as much. Surgical menopause, one day you're making your normal amount of estrogen, and the next day, zip, it's gone. And that's pretty dramatic on your body. And so we tend to have to give more back to account for the fact that there's no estrogen being made from the ovaries because the ovaries aren't there anymore. So for me, I usually start at a higher dose for women that have undergone surgical menopause, especially if it's been recent.
I have too.
All right. The next question is also about surgical menopause. I'm 41. I've been in surgical menopause for a few years now. I get strange adrenaline surges, mostly at night. Is this a menopause symptom? My sleep cycle is also disturbed. I'm tired in the morning and during the day and have more energy in the evenings. Will the pills and cream help with regulating my sleep cycle?
I think they will help with regulating your sleep cycle because it'll give you that stability, from that hormone that's lost. So I think that it would definitely help with that symptom.
Those adrenaline surges that you're feeling may actually be, a night sweat or a hot flash, but it may just be an atypical sort of feeling of that as well, which the hormone should help.
Okay. Here's a question about breast cancer. Is HRT okay for someone who has DCIS stage 0 breast cancer?
Well, so DCIS, for those that don't know, is ductal carcinoma in situ. So this means that it's cancer cells that are, located in one location but have not spread. They're not considered to be invasive. But to me, that's still pre-cancer. That's still cancer. And I wouldn't feel comfortable putting you on a hormone that could encourage that to grow or spread. Luckily, when you have DCIS, it's generally caught early and it can be surgically removed. But I think it's just too much of a gamble to risk that spreading or getting worse.
Yeah, I would agree. Plus, you may be on a medication specifically designed to block estrogen. So, like tamoxifen or one of the other drugs, you may not be, but that's certainly sometimes a treatment. And giving estrogen certainly is sort of counterproductive to that. So, yeah, I agree. I wouldn't think that it would be a good idea.
All right, we have a question about some dosages. The question says, what are some signs and symptoms that would indicate the need to increase the potency or dosage of the estrogen-progesterone cream?
Well, really, we look back at those initial symptoms. Your kitties are so funny.
I'm sorry, there's a whole show going on here. I'm trying to keep them out of the...
I just saw a paw come up and grab you.
He's hanging out. I know.
They want your attention, Mom.
Really
so really what I do is I look at those initial symptoms. And so, we use those to kind of gauge, these symptoms that are most bothersome that you reported on your initial onboarding questionnaire with us. We want to then reevaluate those symptoms. Are they improving or, have you noticed any difference? So for patients that are having significant hot flashes and night sweats and they're just not noticing any improvement at all on the initial dose that we start, then we have to tweak things because obviously the goal is to improve your quality of life and reduce those symptoms so that you have a better day-to-day experience. And so that's really how I gauge whether or not I need to adjust your dosage is by looking at those symptoms.
Angela, we skipped a question I thought was a good question.
Oh, did we? That was what did we skip?
The lady that had a partial hysterectomy and they left part of her uterus.
We sure did. Yes. Sonia, she has a question. She had a partial hysterectomy, kept her cervix, and her doctor said, sometimes they don't get all of the uterus. I'm only on estradiol. Should I also be taking progesterone?
So my feeling is if your doctor told you, we got all your uterus, but we left your cervix for whatever reason, which we do sometimes, I wouldn't be concerned about it. But if your doctor said, yeah, sometimes we don't get all the uterus, that tells me they probably didn't get all the uterus, or at least they're worried they didn't. And so I think that you should probably be on progesterone. Now, I feel embarrassed and guilty because I designed the intake form and there really wasn't a place for you to put that except for under notes. But please message your doctor, maybe it's one of us, and let them know if they didn't start you on progesterone that your doctor told you that there may be some uterine tissue still left behind after your hysterectomy. so they can advise you on that. So, get on the dashboard and send whoever's taking care of you, one of us, that message.
So sorry, I skipped that. Good eye, good catch, Dr. Green. Thank you. That was not intentional. Okay, we have a question about being tired. I'm feeling tired after about 60 days. Should I increase my dose?
Well, if that was one of the significant symptoms that really prompted you to seek treatment and you're not noticing any improvement, then I would write to your doctor and talk about if there's a dosage change that might help with that.
We have another question about dosages and sleeping. Someone says, when I first started HRT with Winona, I slept better than I ever had in my life. Yay. It's been 10 months now and I'm having trouble sleeping again. I read on the Facebook page that switching the DHEA to the morning could help. Right now, I take everything at night before bed. Should I try switching it, or would that really not matter?
I think it's worth a try. I mean, the other thing that could be happening too is that after 10 months, depending on where you are in this transition and your age, your body's own natural estrogen production may have also declined. So you could need a change in your estrogen dosing as well. So I would reach out to your doctor and just let them know what you're noticing. But if you wanted to try to experiment with taking the DHEA in the morning, you could certainly try that in the meantime. But just touch base with your doctor.
You could also try moving the cream. I forgot to say, was she on cream or it doesn't say? But estrogen and progesterone.
Yeah.
For most people, progesterone makes you sleepy. But for some people, it does the opposite, and it can be activating. And I have seen that change, actually. And it's kind of funny because I just changed my wife that way. So she all of a sudden has been having some insomnia. I said, why don't you try taking the progesterone in the morning, see if it helps. We don't know yet whether it's going to work, but that happens sometimes. It's totally okay to experiment with the times that you're taking the medication. You won't harm anything doing that. And sometimes, what works for a while doesn't work so much down the road. I don't know why, for whatever reasons, but it's certainly okay to adjust the timing of the dosage.
Our next question says, thank you to Winona for helping women navigate this time with ease. My question, what kind of change to cholesterol levels will increase in estrogen cause? I am on a statin.
So I haven't seen a significant difference in cholesterol levels for my patients after starting hormones. So that's something that I don't know, it may be a theoretic risk, but I personally have not seen it in my patient population.
Yeah, I don't think it's going to be significant, especially if you're on a statin.
All right, the next question we have is about vaginal pain and dryness. Vaginal pain and dryness during intimacy with my husband. I'm not sure if your treatments would help with this. Your thoughts, please.
So it definitely would. So the vaginal dryness and pain is due to the loss of estrogen from those vaginal tissues. So, when we're young and healthy and in the prime of our reproductive life and we have all of our normal hormones, the vaginal tissues are thick. We have normal folds, or what we call rugations in the vaginal tissue, that allow for, more elasticity, more suppleness to that tissue. And also we have natural lubrication that helps, with intercourse as well. So in the perimenopausal and menopausal transition, as estrogen is lost from those tissues, the tissue becomes thinner, becomes more brittle. You can have like a burning or dryness sensation, pain. So one of the first things I always encourage patients to do is always use lubrication with every active penetrative intercourse. That's really important as you're going through this transition, because you don't want to traumatize that tissue. Now, if you start estrogen replacement therapy, it will help no matter what route the estrogen is, but it may take some time for the systemic estrogen therapy to really help the vaginal tissues. So if this is really a problem, a really bothersome thing to you, and your sex life is important, it's important for everybody, I think. We could also offer you topical estrogen cream as well. Vaginal estrogen cream is what I mean, because that will deliver estrogen directly to the vaginal tissue, and it will give you a more rapid return of the elasticity and the thickness of that skin, rather than waiting for the systemic hormone replacement therapy to help. So we could actually have patients on both. We start systemic HRT with either one of our body creams or pills or patches. But because the dryness in the vagina is such an issue, we can also use vaginal estrogen cream because it's not really absorbed systemically. So it typically, just absorbs locally, and it helps with that issue tremendously. So you can talk to us about that, and we can do that for you as far as a treatment option.
Okay, the next question is 4 questions. Are you both ready?
We're ready.
4 questions.
4 questions in 27 parts.
1A, 1B, 1C. Okay, it is first question. I've been taking HRT for 2 months, and some nights my hot flashes are worse. Is there anything I can do about that? So we'll start there.
Well, I guess it all depends on quantifying the sum, so we say some nights they're worse. I would want to know, what is, how frequently is this happening? Is it something that is happening more often than not? Because it might mean that the dose you're on might need to be adjusted. There's a lot of other factors that can exacerbate your vasomotor symptoms, like hot flashes and night sweats. So if a patient is under a lot of stress, if they've been sick recently, a lot of other factors can affect that. If you're not sleeping as well and you're sleep deprived, you can have more hot flashes, night sweats. So take a look at your day-to-day schedule, try to see if you can kind of track the frequency of when this is happening, and we can see if adjustments are needed.
Question 2 is, do I need to take the HRT always at the same time in the evenings?
Important. Yeah, sorry.
Go ahead. No, go for it.
The timing isn't so important. Taking it every day is important. It's not like a mini pill where if you're off by a couple hours, it's not going to work and you might get pregnant. So the HRT, there's a lot of wiggle room in this. One of the reasons it takes a while for symptoms to improve is it takes a while to get what we call a steady state blood level. And that's because it has a fairly long half-life. The nice thing about that is that's the reason we can dose it once a day. It also means it has a lot of wiggle room in when you can take it and still be effective. However, for some people, they're more sensitive. And so there are some people that find if they change the time they take it, their symptoms can, improve or get worse. Kind of we were talking about the previous patient. So, sometimes if your big problem is sleep issues, getting it right at bedtime may be the way to go. If on the other hand, it seems to be not helping so much with sleep, changing it to the morning might be the way to go. So playing with it, adjusting with it is okay. If you're, like someone wrote me in, oh my gosh, with daylight saving times, how do I adjust this? You don't have to worry about that. It's really not that sensitive to time, like some of the other medications that you might take.
The next 2 were listed as questions, but they're sort of more informative statements. So the next 2 things say, I also tend to urinate more often ever since I've been taking HRT, and my sleep has not improved.
So most of my patients actually notice the opposite. So, sometimes the loss of estrogen we notice from the vaginal area, patients can get some bladder irritation, some increased urinary frequency and urgency just related to the loss of estrogen from the tissue. And so when we replenish the estrogen, usually those symptoms get better. Also in this, sleeping usually improves with hormone replacement therapy. So I would touch base with your doctor if you're on our treatments and see if something needs to be adjusted.
And then, again, it may be one of those things like I just talked about of changing the timing of the medication as well. You may be one of those people that taking it at bedtime makes things worse. Taking it in the morning will improve it. Everybody's a little bit different. So that's something that you can do, as well.
Great. Dr. Kat, I think you're frozen also.
Am I frozen?
You're frozen.
No.
I can hear you, but you're
I see her moving.
Do you? Mine is frozen.
Oh no, maybe it's your internet connection, Angela.
Maybe. Sorry. I just thought in case it was frozen for everybody, I would give you a heads up. But if it's just me, that's no big deal.
At least I'm not disappearing this time.
Oh yeah,
Right.
That was a cool trick.
Yeah, you had some magic happening last time.
I decided to use my personal laptop instead of the hospital computer. I think that it was sabotaging me last time.
That's it. Yep, that's exactly it. We have an interesting question. I haven't seen this before. Is there a written prescription I can get for international travel?
So the TSA rules, and I assume they follow internationally, is as long as it's a prescription medication, you're allowed to use it. So for instance, the creams, the bottles of the cream actually are all under the TSA amount, but even so, as long as it's going to have a label, and so it has a prescription label on it, that should be good enough for travel. They shouldn't confiscate it. So you don't need actually a written prescription to go with it. The pharmacy sticker should count for TSA or other screening agents.
Okay, the next.
And by the way, you want to put this in your carry-on. Don't put this in your pack baggage.
Yeah, because the cargo is not temperature controlled.
Yeah.
Those are both good.
That's true for all medicines, by the way.
Right.
It's a little life pro tip right there.
Yep, that's it. Thank you, both of you. That's excellent. I did not even think about that. Okay, the next question wants to know, how will I know if I'm on the correct dose? I just started treatment.
So you'll know you're on the correct dosage if your symptoms are improved to your liking, really. So, looking at your initial symptoms that you reported, if those are improving and you're noticing that, they're not bothersome as much, your hot flashes have reduced, night sweats have gotten better, it's really about your quality of life and your experience in your life day to day. So if you're happy and you're satisfied, that means it's the right dose.
I like it. Okay, this is an interesting question as well. After you've been on HRT for a few months, can the dose be decreased to reduce risks or side effects?
So that's a reasonable thing to do. I would probably wait a little bit longer than a few months, but when you're on a stable dose, you're doing great. It's not unreasonable to try lowering the dose and start titrating it down to see what you can get away with. My opinion is that the least amount of medicines that we need to take to make things work, safer and then better. And so I think that's a very reasonable approach, but it may take longer than a few months. I probably would wait a little bit longer to try that experiment. But I think it's a very reasonable way to go.
And then you might notice a resurgence of symptoms as you decrease. And so we have to kind of play it by ear and kind of see how that goes.
All right. We have a question about hormone levels. As a Winona patient for 3 months now, I understand hormone levels fluctuate greatly throughout the month, and testing is not recommended for this reason. I'm curious how HRT fills in the gaps with natural levels being so inconsistent. Is the overall goal to increase the baseline? If so, are there any benchmarks aside from symptom relief to dial this in? As an engineer by profession, I always try to understand things in terms of numbers. Thank you.
Yeah, so unfortunately, unlike your engineering career, there's not an objective number necessarily to say, yes, this is the perfect treatment for you. It's really about how you feel. So it is true, by providing hormone therapy, we're trying to give you a baseline level and a more consistent level of hormone in your system. So we have the hot flashes because of the roller coaster of our body's own production and then loss or lack of production. And so the hormone levels are up and down. So by giving you the hormone replacement, we're giving you a steady state dose of those hormones, which helps to reduce those symptoms. So it really is based on how you feel. I wish I could, have a little litmus test that says, yep, this dose is perfect for you because you have X, Y, or Z, but it's just not practical to think about it in that sense. So you have to let go of the objective data on this one. It's more about subjective and how you feel.
So I have a master's in organometallic chemistry, and with a big thesis and everything. And the way medicine's done, when I went to medical school and started seeing it, kind of astonished me as a hardcore pure scientist. I think as an engineer, it would you as well. It's amazing how subjective things can be. They call it the art of medicine for a reason. I'll tell you, the biggest thing for me was pathology. These guys get slices of tissue, they're looking at a microscope. You think they could tell you, is it cancer or is it not cancer? Sometimes even that, it's hard to tell, and they have to send it off and get different opinions. So medicine isn't kind of disappointing. It's not as cut and dry and it's like perfectly scientific as we all like to think it is. There's a lot of art of medicine involved, and a lot of trial and error to get the right thing for you. The human body is so complex that it's really almost impossible to generalize that this thing at this dose is going to work for this patient, because there's so many variables that you can't account for. So it's not so much like an engineering project, unfortunately. There is art to engineering as well. You give a problem to 3 different engineers, they'll come up with 3 different solutions. They should come up with the same answer, but they'll come across it from 3 different ways, and that's actually kind of cool too. But yeah, it's not. Unfortunately, it's not like engineering. It's not really numbers and pure science that way.
Okay, we have a question about ovarian cancer. It says, how is it that a risk factor for ovarian cancer is HRT, but yet taking birth control pills can be a form of prevention? Is that strictly due to the difference in the levels of hormones between birth control and HRT? The info seems almost contradictory.
I'm going to give this one to you, Dr. Green.
So I would take issue with the first part of that. I don't think HRT is a risk factor of ovarian cancer. I don't think that that exists. The birth control pill is interesting, and the reason, at least my understanding of why birth control pills decrease the risk of ovarian cancer is it decreases ovulation risk, or not risk, but it decreases ovulation. And so it decreases cell division within the ovary itself over a chunk of the lifetime. And anytime you decrease cell division, you decrease the risk of a cancer forming. So my understanding of why birth control pills decrease the risk of ovarian cancer is they stop the ovary from ovulating. And they really kind of shut the ovary down to some extent, almost push you into menopause and then take over with the hormones from birth control pills. HRT doesn't do that. It doesn't stop you from ovulating if you're ovulating, which is why I always warn patients that are, still have the risk of pregnancy, that HRT is not going to protect you from pregnancy like birth control pills. So that mechanism is very different. And so if HRT doesn't have the same protective effect of birth control pills, that would be the mechanism. I don't think that HRT increases the risk of ovarian cancer. I'm going to have to do some research now, but it's not on my list of worries.
Yeah, I haven't heard that either, which is why I punted the question to you.
Well, look, everybody's in agreement, so that's good. Okay, the next question is, what hormone helps with sleeping well?
Well, as far as your female hormones, having consistent estrogen and progesterone can help. But as a physician who works shift work and overnight shifts, I could tell you that melatonin is pretty helpful with sleep as well. But we're talking more about hormone therapy now rather than sleep aids. So giving you a more consistent dose in your body of your hormones can help with that. But like we talked about earlier, sometimes for some patients, progesterone can help with sleep, and it can make some patients feel the side effect of feeling drowsy. So that can sometimes help as well.
Yeah, I think a lot of times it's hard to tease out the hormones. The estrogen, progesterone, and testosterone really sort of work in concert in a lot of ways. And they're, one may be sort of dominant for one symptom over another, but they sort of work together. And I think it's hard to tease out exactly, this one does this, because they kind of work together. And especially for sleep, there's really benefit to both estrogen and progesterone for a lot of people, I think.
We have a question about cystic acne and DHEA. Someone stopped taking DHEA due to cystic acne and itchiness. They've been taking it since September of last year, and they want to know if it's common. They're still using the cream, though.
Well, so, acne is a potential side effect for patients with the DHEA. I've had a lot of patients that don't experience it at all. I've had some patients that get mild breakouts. And usually the patients that I've experienced that have had cystic acne have a significant acne history. And so it's almost like it's triggered, by the medication. So if you seem like if your skin has cleared up off the DHEA, it might be that you might be one of those people that have a propensity toward that. But I've also had patients that start DHEA, have problems, some acne, and we go off of it. And then after they have been well established on the rest of their HRT, then we kind of restart introducing it again, and they do better the second time around. I don't really know why they do better the second time, but I've had a lot of patients that retry it and they do better later.
Okay, the next question. If someone had breast cancer more than 20 years ago or has a family history of breast cancer, can they use HRT?
If you've had a personal history of cancer, I would say no. It's not a great idea to use hormone therapy, but a family history does not preclude you from being a candidate.
So there's no length of time in which it's okay, whether it's 5 years or 20 or it's just period.
No. So, the thought is that once you have cancer, you're always at risk for that cancer to come back. So why put a substance in your body that could potentially encourage that to happen more readily? So any kind of history of cancer, I'm a little reticent to prescribe, even if it's not a GYN or breast-related cancer. I'm still kind of reticent to give you hormones if you've had a personal cancer history.
Yeah, I would agree with that.
Okay. We have a question about, anybody have a life hack on how to get the patches that sometimes come off? Is there maybe a trick to make sure they stay on other than oil-free, clean skin?
Yeah, so oil-free, clean skin. The other thing is I've always encouraged patients to not put patches anywhere where the seams or the waistline of your clothing or cuffs of clothing, buttons, or anything is going to rub against it, because any kind of friction would encourage the patch to detach. Now I'm rhyming. The other thing I've had patients do, if you notice that the area on your skin that you want to apply the patch tends to have more natural moisture, I have had patients try to apply powder and then kind of wipe it off to kind of really dry the skin before applying the patch. And that's gone for birth control patches as well as hormone patches. And if you're somebody who's very active, like if you're a swimmer, if you run a lot and you sweat in the area and you're worried about it coming off that way, there's actually things that you can buy at the store, at the drugstore. Something we use in medicine a lot called Tegaderm, which is basically a clear, it looks like a cellophane bandage. It's just clear plastic, kind of very thin, like a skin. And if you have a problem with the patch coming off, you could get Tegaderm, like even the CVS or Walgreens or whatever drugstore brand, and put it over the patch to kind of help it stay applied if it's an ongoing issue for you.
Also a really good tip. Also a good tip. Okay. The question is about HRT. Can it cause less of a urine stream or flow and cause less frequent urination?
Potentially. So I talked about that a little earlier when we were talking about the patient that asked with increasing urinary frequency. So when you replenish your body's estrogen, the tissues in and around the vagina, which is adjacent to your urethra where the urine exits your body, they do become more supple and the tissue becomes healthier and thicker. So if your vaginal tissue was kind of devoid of estrogen, that urethra might be a little bit more patent or open, and as the tissue of the vagina kind of thickens, it might make that opening of the urethra a little bit smaller. So that could affect your stream. Also, just strengthening those tissues around the bladder and giving the bladder more support can also increase the bladder's ability to fill and not empty as frequently. So, if the bladder's irritated, you have to pee more frequently, and so this can help with that.
Okay, we only have a couple more questions, actually 3 more. Okay, this question asks, which areas are the best places to apply the bi-estrogen cream?
So my favorite place and where I apply it, because I use it, is to just put a pump on my forearm, and then I take my 2 forearms and rub them together so I don't lose any on my hands. That's what I've been encouraging patients to do. So
The general rule is any area of the skin that doesn't have hair follicles, except over the breast. The hair follicles have enzymes that can convert the hormones in ways that are disadvantageous, that don't help you. So better to put it on. So the trick with the rubbing the forearms together is a great way to do it. Some people are worried. They hug their kids or what have you. You can put it in the inner thigh or the back of the knee or other places that tend to be popular.
Question says, I switched to progesterone-only birth control and noticed weight gain. I have since started HRT. Will that help with weight gain?
So if your weight gain is hormonally related, then starting HRT may help with that. But we really have to kind of see how your body does.
Okay.
The progestins in birth control pills can stimulate appetite. Depending on which progestin-only pill you're on, some of them are sort of famous for that. In fact, there's a progestin that is specifically used to stimulate anorexic people's appetites. So that is a known side effect of some of the synthetic progestins. And so it's possible that's why you were gaining weight with your birth control pill.
All right, the last question we have says, I'm starting my 3rd week with estrogen cream and DHEA. My sleep has greatly improved, but I notice I am nauseous several times a day briefly. Will that change with continued use?
So it may improve. I'd be curious to see what, you said estrogen cream she's on. So depending on when you're getting nauseated, sometimes I can tell patients to change the time of day that they're administering the medication or taking the medication. If you're taking both of them together, sometimes I'll even encourage patients to kind of separate and then see where the nausea occurs to see what medication is the culprit of why you're getting that side effect. But generally, most side effects are transitory. It's as your body is acclimating to the medication and they get better with time.
That's all of our questions. Do we have any?
I have a question for you. How many different cats have I seen roaming around?
I have 4 cats, but I have, let's see, there's one on the back over here behind me. That's Puma.
The black one, yeah.
And then the white one gets along so well because they crawled all over the black one. I thought we were going to see a cat fight.
You might have. She's so sweet. She's really old, and my other 3 cats are all boys, and they're about half her age. So they're a little rowdy, and they tend to, be rowdy boys. So, yep. But they all usually vie for attention at some point here. But today they were pretty well behaved. So.
I think about every video meeting I've ever been on that people have been home, there's been a cat that somehow, once they see the computer and your attention to it, they want to go right beyond, right past the camera.
There are so many things that were happening while we were speaking. I had a cat that I could hear in the bathroom. He sits on the toilet and he rolls all the toilet paper off because you pay attention to him. I could just hear the roll in there going ding, 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 ding. I'm like, that's how that is. So yeah, they're fun. They definitely are like little children. They want your attention and they do things so that you'll pay attention. Yeah. So thanks everybody and everyone who gave us really interesting and helpful questions. Thank you. And I think we should remind everybody that in 2 weeks we have another webinar for prospective patients. So any current Winona people that are here, if you have friends or family who need assistance or in menopause or perimenopause, you can send them our way. We'd be happy to help. And one or both of you will be here next time to answer more questions, right?
Right.
Yes.
Okay, good.
Great.
So
and don't forget, you don't have to wait for the monthly webinar.